And Isha, maybe you can continue with your
clinical presentation.
Clinical presentation, because Somsila is delayed.
Sure.
And if you have any question, please ask, interact. We want it to be very interactive. So far, if there are any questions, please do ask. Otherwise, Isha, you can go ahead with your next talk.
Okay, so when we get a patient of PUK in our clinic, what are we supposed to do and how are we supposed to proceed? As Dr. Sangwan had mentioned initially, that PUK is not just an ophthalmic disease. It has grave systemic implications if missed. So, and a lot of times the ophthalmic presentation is the first presentation of the systemic disease as well. So as an ophthalmologist, we have a responsibility that when we see a patient of PUK, we investigate them systemically and refer them to the right place to get that part of it also treated. So I'm going to start the clinical presentation with two cases. So the first case is of a 70-year-old male who presented to us with redness, pain and diminution of vision in the left eye since the past 4 months. He was already on systemic steroids and topical lubricants when he presented to us, and his systemic evaluation from elsewhere had a raised ESR, but the other tests were within normal limits. He had had multiple ocular surgeries before, TRAB in both eyes, phaco, retinal injections, and he was on anti-glaucoma medications also. The right eye essentially was within normal limits except for a bleb and a higher cupping, but the left eye had peripheral thinning, as we can see here, with an epithelial defect, and there were subepithelial infiltrates as well. So as we treat a normal ulcer, we did a corneal scraping and did not find any growth. We did some basic blood investigations. Again, we found our ESR to be raised, and the other investigations are within normal limits. And as we had no fungal hyphae, no growth was seen, we started the patient on prednisolone acetate 2-hourly, oral prednisolone as well, with the homotropine lubricant, and continued the AGMs he was already on. By day 10, the patient had symptomatically improved. Lid edema was still there, congestion had reduced, but a crescent-shaped thinning was still present. By day 15 and day 25, the patient had improved drastically. So the steroids were tapered and lubricating eye drop was continued. The patient presented to us 1.5 months later with increased peripheral guttering and thinning, and this area was also taking up stain, which means it was without an epithelium. So such a lesion has a very high chance of perforation. So we planned a patient for a TABCL with conjunctival resection. So after 8 months, this patient was doing well. Coming on to the second case, the case was of a 71-year-old male who presented with pain, redness and diminution of vision in the left eye. He was a known case of rheumatoid arthritis, but since the last 3 months he was not taking his medications. He was also a diagnosed case of cardiac disease. So on presentation, his right eye had a scar with superficial vascularization. Left eye had a perforation which was around 3 into 3 mm with iris tissue plugging it. So we diagnosed the patient as right eye healed PUK and left eye PUK with a sealed perforation. So what we wanted to do was to give IV methylprednisolone and plan his blood investigations. But because of his cardiac dysfunction, we could not give him IV prednisolone or take him up for surgery under local anesthesia as well. So we started him on steroids again, both oral and topical, and investigated him. So all his investigations were off the charts. His LFT, KFT, RA factor, anti-CCP, everything was abnormal, both ESR and CRP as well. So these had to be normalized before we could take him up for any procedure or give him IVMP. So we did a physician referral who started him on hydroxychloroquine and supplements along with it, and we were waiting for the LFT to get normalized before we could start methotrexate. So by day 10 on steroids only and after the treatment was started, the patient had symptomatically improved, the chemosis had resolved, the congestion had reduced, and the perforation also had become, the iris plugging had also seemed to reduce, maybe because of decrease in edema. So the same treatment was continued, and by day 17 the patient was much better and scarring had taken place over the area of the perforation. So steroids were tapered and the rest of the treatment was continued. So by 2 months, his LFT had normalized and the patient was started on methotrexate as well. So by these two cases, we can see that we may or may not find a reason for a PUK, but the management has to be tailor-made for each and every case depending on what are the other associated factors. So essentially, a PUK presents with a crescent-shaped peripheral thinning, as we can see here. The edges are overhanging, there is associated congestion, and the central cornea may or may not be involved. If there is diminution of vision, that could be because of the inflammation or the astigmatism the defect is causing. It is mostly unilateral but can have a bilateral presentation, can present only with a defect or be a perforated presentation. It may or may not have an infiltrate, but when there is an infiltrate, a corneal scraping, like how an ulcer is scraped, is to be done. It has to be differentiated from a Moran's ulcer, which is essentially a ulcer which is like a PUK. It's more chronic, serpiginous in nature. It is not associated with scleritis. The pain in a Moran's is out of proportion to the signs. We are not able to find any systemic cause for it, and there's no clear zone of peripheral cornea. So what do we do when a patient with a PUK walks into our clinic? We obviously check the visual acuity. On a slit lamp biomicroscopy, first we assess the patient in an unstained, first we don't stain it. We look at the clock hours of thinning, presence or absence of any infiltrate. If the eye is congested, we have an idea that it is an active disease. Sometimes the patient presents in a quiet eye which may not have an active disease, maybe a thinning because of a prior episode of PUK. Look at the anterior chamber depth, because if there is a small perforation also, the AC may be shallow to flat, and a careful digital tension to assess if the eye is soft. Then when we stain the patient with fluorescein dye, we see that whether the area of the guttering or the thinning is epithelialized or not, because if it's epithelialized, then we may not want to surgically intervene unless it is for optical reasons. We do a Seidl's test to look for any perforation, and because autoimmune diseases like RA do have a dryness component, we look for the extent of the dryness as well. If the patient is cooperative, we can assess the fundus. If a scraping is needed, we send the whole thing like a gram stain, KOH, culture. And for the blood tests, now these blood tests are very expensive tests, and not everybody can afford the whole battery of tests that we want to do. So maybe we can start with the basic tests and proceed to the higher ones in case we feel that something is wrong, something is suspicious. So a CBC, ESR, CRP, a blood sugar, kidney function and liver function tests can be done in all cases. And depending on what systemic condition we are suspecting, we can go on to do the other tests, specific tests as well. So there is a whole list of these tests that we can do, and a whole list of signs and symptoms that we can elicit and ask the patient in their history and examination to look for any other conditions. RA being the most common, we can ask for morning stiffness. The small joints are affected more than the larger joints, and such deformities can be looked for in the clinic, and a lot of patients do present with such deformities because their RA has gone undiagnosed for very long, or they have been very reluctant to take treatment for this disease. In the end, I would just want to say that a collaboration with the rheumatologist is suggested, because a lot of times we may not know what is the extent of the systemic illness and what is the treatment that we'll want to give, which is appropriate for the patient. So again, for those who have missed, can scan the QR code here.
Very nice presentation, Isha. Yeah. Any questions or comments for Isha? Or she showed two different cases. One had a clear-cut systemic component, the other one did not. So any of you have any comments to make or any question?
Yes. Sorry?
Can you speak it, doctor? Can you speak?
Brimonidine. So the patient was a known case of glaucoma, had undergone TRAP, had an advanced cupping. So that treatment was going on from before, we just continued it.
Any other questions, comments? So it has been now known that even the medication that are used for glaucoma can cause this kind of peripheral ulcerative keratitis, especially if it's inferior. Yes.
How to, doctor's question is how to investigate Moran's and otherwise PUK. Is Dr. Dalia said here? Okay, we will after this we will have listen to your talk and then we'll continue with the rest of this. Thank you very much for the patience. So see, Moran's ulcer is a specific morphological clinical type, and if you review the literature, there is excellent study and done by in our country. There is something called Watson's criteria for diagnosis of Moran's ulcer. So in Arvind, Dr. M. Srinivasan and their group, along with the group in US, what they did is, okay, we will take clinical diagnosis of Moran's ulcer, and then we will investigate them thoroughly. All collagen vascular profile, ANCA, we'll do CT scan, we'll do all, and they wanted to see whether it is really true that there is nothing positive in that. So that was a very good, well-designed study, and in that they proved that if clinically there is a Watson criteria fulfilled, you don't need to investigate those patients for etiological diagnosis. You may do CBC, LFT, X-ray test for management. Why management? Because you want a baseline, all these parameters, and if the patient need immunosuppressives, you would want to compare them with the baseline. So doing the diagnostic investigations has two different roles. One as a baseline, parameters, and for etiological diagnosis. So for Watson's criteria, it is a specific type of Moran's ulcer with the crescent shaped, with the advancing edge, the receding or the trailing edge is healed, and there is no scleritis, there is no associated collagen vascular disease, and I think these are the 5 criteria. Yes?
Yeah. So in addition to what Dr. Sangwan said, it's important to know the severity of what you're seeing. So just as a show of hands, how many in the audience would call themselves ocular surface specialists or cornea specialists? Right. So if you are an ocular surface specialist or a cornea specialist or someone who deals with autoimmune conditions of the cornea and the sclera, then it makes sense to go into all this and into the depth of all this. But in 2025, if you're really not managing these conditions on a regular basis, or you don't have the training or the tools to deal with this, my recommendation would be not to do any investigations and to try and find an appropriate specialist who can deal with this, because it can cut both ways. You may have cases which really do not need too many investigations and you unnecessarily spend time and money, and a lot of investigations are done and nothing comes up. On the other hand, you may have cases which...
Even cases you random investigation, something comes positive,
yes,
and you don't know how to correlate. So then you start chasing that investigation rather than the disease.
So the patient may be over-investigated and over-treated. At the other end of the spectrum, you may have cases which look innocuous but which may have a systemic component you need to really work up, and you might miss that. So my recommendation in a nutshell is that rather than trying to investigate and go into the... Of course, the handbook is there, you'll find all the information. But if I were a comprehensive ophthalmologist, I would just send it to the nearest person who is trained to look at all this.
The investigation, there is another downside, is that if we find something which we don't know and whether it is a cause and effect, and we may mislabel the patient, and then the patient worries a lot that okay, if ANCA positive and you don't know whether it is really positive or not, and then you may say okay, it is Wagner's. So patient will start looking for that in the internet, and then you may, they start getting worried unnecessarily. So it's very important role that we physicians have to play, that balanced activity.